So, thank you very much for the opportunity to speak today. It was a real privilege to listen to many of the stories, especially the ones earlier today. And I think just if I start by saying I'm a clinician and I retain a passion for clinical practice and care. I'm an NHMRC practitioner fellow and I retain a true passion for research. I am incredibly disillusioned about the lack of integration between those two. And anyone who thinks that you're here today just to think about research, I think we are seriously mistaken if we don't bring those two things together. So my talk is about systems level change, responsibility and accountability. So it's a beautiful segue earlier into what we need to do, because the reality is that most clinicians, and I'm using that term broadly, who go into healthcare care about the people they partner with and would like to provide the best care they can. Most CEOs of hospitals want to provide optimal care. Most researchers want to think that their research leads to better outcomes into practice. So if we have all of those things aligned, why can't we do it? And I've spent an incredible amount of time thinking about this and looking at the evidence, and it doesn't come from our literature, it comes from a social sciences literature and management literature and literature about engagement and partnership. And that's not in our typical health and medical research literature, and it's hard to read. But I'm going to take you on a little bit of a story. So I'm going to talk about disruption through collaboration and overcoming systems level challenges. I can get this to progress. Yes. So these are the vital facts and perspectives I'd like to start and leave with you today. Our community are the funders and the beneficiaries of healthcare. That is everyone in Australia. Not the politicians alone, not the clinicians alone, not the healthcare providers alone, all of us. Our community in Australia are the funders and the beneficiaries of health and medical research. We spend a great deal of money on both of them. And yet they have very little accountability to us as a community to deliver what we would want. We all are the collective custodians of health and research for the benefit of all Australians. Not one sector amongst us, but all of us. Healthcare improvement is not competitive. If Sydney Partners has the best way co-designed to assist people who have a heart transplant, everyone in the country has the right to have that system. We should not compete, and there is no space for competition when it comes to healthcare improvement, yet research in Australia and around the world is totally entrenched in a competitive paradigm. Even healthcare in Australia is entrenched in a competitive paradigm. I'd like to provide fantastic integrated care for my patients, but I can't because the state is offset against the federal government and we're cost shifting and competing from one against the other. Competition has no place if we're looking for healthcare improvement. And the other thing I'd like you to think about is nothing about us without us. And the concept that we should not be designing anything, and that's about the community, but it's also about our political leaders who genuinely have a fairly strong will to have a really good system, but somehow think they're alone as custodians of our system. And obviously we all need to work together in this. So why can't we do the simple things we talked about? Why can't we overcome the challenges we've heard about? We have competitive silos and we have old power systems, and we heard a lot about this yesterday. Our community health, our primary care, our hospitals are competitive. They are not incentivised, in fact disincentivised to work together. And research is not incentivised to work together with them in any way. And this is the biggest problem. It wasn't until I really understood this, and this slide is actually from Gary Jennings, who's in the audience, who's the director of the Sydney Partners, but it's really important. In our hospitals, what do we measure? Processes, episodes of care, waiting times, patient flows, and quality metrics. Interestingly, even the quality metrics we implement actually drive perverse behaviours in themselves. If we're in primary care, this is in Australia not a system, it's a cottage industry, and they're essentially private businesses. If we're in a medical research institute, it's all about bibliometrics and grants, our best researchers, and it's all about an investigator-led paradigm. And they behave in that way because that's what we reward them for, and that's what we tell them they have to achieve. And it's the same in our universities, and if we're looking at education, it's all about student enrolments and numbers and revenue and international students. That does not create a system that gets the best of our research to address our biggest problems for the best outcomes. But that's how we set our system up for all of us to work in, and then we say, why can't we overcome it? Why can't we work together to do better things? There is nothing in there. So I'm an NHRC practitioner fellow, and every time I do research and go to translate it, I am not rewarded at all for translating it because I'm not publishing. I've got to be publishing, I've got to be getting grants, but I'm supposed to be doing something with the work that I've just co-designed, and I'd really like passionately to see impacted and scaled. But I'm actually having to work against the system to do that. Clinicians would like to provide flexible care and be able to get on their app and give the patients at home their results so they don't need to sit in a waiting room for 3 hours, but they can't do that because they're allowed to within the system. They're funded for episodes of care, which is face-to-face care. So the system does not allow us to do what we want to do together. So what we have is a system, and when we're talking about healthcare, with an age and respite care as a classic example, we're all driven by these perverse funding pots that allow us to go here and there, and then at different stages of our disease we have to go somewhere else. And often the employers are all disparate and people don't even understand what the system looks like. There is not a single component of our medical curriculum in our university, which is the largest university in Australia, that teaches any of our health professionals about the health system they're going to work in. They don't know there are 87 devolved hospitals with 87 boards in Victoria who actually all do their own thing. They don't understand the federal and state challenges. They don't understand the system they're working in. But we have all these perverse drivers and we can't hit the mark about patient-centred care because the system doesn't allow us. So what we end up with is one of these burning platforms. And I'm going to come back to the fact that we actually do have a very good health system, so we're in a really good position to do this, but Australia can collaborate. We can do so much better. And we need to fix this, and the burning platform was set up beautifully by the patient experience we've just had. And some of my experiences and perspectives come from, in fact, this person who is my gorgeous, darling father, who died after a fairly torrid and awful journey with cancer for 2 years. And I was his patient advocate. I was his support person during that journey. I was never his doctor or his medical person, but I advocated for him during his journey. And I can tell you there were many learnings along the way. And one of the things that's interesting, we don't have time to touch on today, but being a patient is not the same as being a consumer, and we've actually had that alluded to today. There is a whole body of evidence that shows a patient is not an empowered consumer. When you are sick and in care, the problem is not the word, the problem is the way we treat and conceptualise and the assumptions that we have around the concept of being a patient. If you've been in care, I've been in care, I had a wonderful skiing accident and ended up crucifying my knee. And when you are lying there unwell and sick, you are a patient, you are vulnerable and you're feeling disempowered. And we need to understand it's not necessarily about the words we use, but the way we conceptualise it and the way we partner in care. So the other problem we have is we have reductionist thinking. An expert knows more and more about less and less until they know everything about nothing. And that's actually where we're heading in clinical care, because it's easier to be a specialist than it is to be a generalist. That is a workforce trend that is not necessarily in the interests of the patients and the community. This is actually what the Productivity Commission says our health system should look like. Patient at the centre, power to make decisions, getting outcomes that matter to people, affordable, accessible care, good experiences and access to data. This is not what we can have at the moment with our current system and our current drivers, and our state-federal divide is one of the biggest reasons for this. One of the other challenges we have, so we have all sorts of challenges in our health system. What about our research system? This is the current health and medical research paradigm in our strategies at the moment, our policy strategies. So Jim Bob, who's a microbiologist with a pipette, maybe brilliant, is down here at his basic science lab. He knows nothing about the health challenges in the community or the burden of disease, and he starts doing something in research, and somehow over 17 years, with an attrition rate of 99%, he's supposed to solve the problems that you have with your husband with dementia and you have with your heart transplant. There was no consultation about what the priority was, what the real problems were. There was no defining together what that looks like. It wasn't iterative, and we wonder why we have all these valleys of death along the way, because we're not defining the problem and coming up with joint solutions. If we came up with the solutions, the community, the healthcare providers, the system would eat them. There wouldn't be any valleys of death. But we don't do this together, so we have single lens perspectives. Solutions from policymakers are single lens perspectives from that direction. Solutions often from clinicians are the same, solutions from researchers are the same. It's not until we all come together with the consumer and the community perspective that we actually overcome that. So in research, we really have all power, and it's very, very hierarchical and structured. And the other thing is we don't do it strategically. We fund one piece of 1,000 puzzles at a time. It's all about the investigator-initiated. And if they do great work with a 10% success rate, they're not even going to get to succeed to have that strategic system to actually get the best out of health and medical research investment. We really have reductionist thinking, again, in research. So you can see these repetitive problems at a systems level. But we are starting to see the winds of change. So this is from the Health and Medical Research Review, the Strategic Review in Health and Medical Research. We're all supposed to come together as one happy family and not just be about researchers anymore, but about healthcare professionals and investors coming together to create a high-quality system. What's missing? The community and the patients who, remember, are the funders and the beneficiaries of everything we do. This was an excellent document except for the fact that it left out the patients and the community. So if we do all start together to work together, surely we can just create great change and do really good things. But the reality is we haven't had a platform until recently to all come together. What if we had a place where public and private organisations could come together? The reality is up to 51% of Australians have private insurance, and yet we don't often include them in this innovation system. What if primary care and Indigenous and public health, universities and research institutes, state and federal government, if we could get them to work together, it would be amazing. Philanthropy and industry and community and consumer partnership. What if there was a structure and a space we could work together? Well, that's what these RTECs are all about. That's what Sphere is all about. I would propose to you, Sphere is not about research. It's actually about a paradigm shift to get all of us in the tent together and overcome those systems challenges and do things so much better. We are bringing health services together, research, education and capacity building. We are not like some of the international systems. We are not university-led. We, by definition, are health service-led. How you define that in your system is going to be really important. It doesn't mean the health service is going to do all the research. It means the health services are ideally going to set the priorities, and the researchers are going to partner with them and the community to deliver that. So we end up with a scenario where we get prioritised strategic research within an integrated system that actually lets us generate evidence and actually get it out into practice. So we create a community of practice where we can do really good stuff together despite that system we talked about. We embed education and research in healthcare, not silos, but all together. And we disrupt our highly dysfunctional concept of research by having iterative processes, by having patients and community and health service providers have a legitimate voice, and government, about what we need and how we're going to define the problem and work together. And we create a pool for the evidence we need. So we have this system, as we said, where we're all pulling in different directions, which does not allow us to achieve what we want to achieve. I'm going to go back one. So what if we had a system where instead of student enrolments and higher degree completions and health industry as a source of revenue, what if our system was that employers and the community had significant influence on the design of the curriculum we have for our doctors and nurses? What makes us think a university should be the only person, the only entity designing the curriculum? What if we had a mandatory requirement for our courses to actually create a workforce that we really want and we really need? What if instead of bibliometrics and grants, we actually changed to impact metrics and said to the universities, we'll give you part of your funding on the impact that you have, and that is not your impact factor in your New England Journal and your JAMA. It is the impact of that work that you do. What if we said to them, you can't present us with a panel of leaders of all men, you have to have better balance, and we need to have female leaders in there, we need to have early career. Or you can't apply for the funding that you need to apply for. What if primary care had patient-reported experience measures, patient-reported outcome measures, quality measures? And what if our hospitals had patient-reported experience, not the one we ask them at the moment about their car parking and the quality of the food and the television, patient-designed experience measures, patient-designed outcome measures? I wanted to decide whether or not I needed to have my knee reconstructed. And I found evidence on the type of surgery and a bit on the long-term side effects, but I found none of the evidence I needed to inform me to make a decision. I wanted to know, my biggest problem was X, which happened to be hiking and skiing and joint stability, which was all about patient experience. I couldn't find a single study that informed me about what I wanted to do and whether surgery would make that any better. And just really, in a very simple term, we don't tend to think about those things. What if they were the metrics that drove our system? This is possible, it is happening. In the UK, 20% of university metrics are impact metrics. They have changed their behaviour. Sally Davis said to the universities, do not come back to me. You are not eligible to apply for your academic health science centres unless you are all Athena Swan Silver. And Athena Swan Silver recognition means you have to have proactive promotion of women in your organisation. Don't apply unless you've got it. So they change their behaviour. Then we start to see things like quality metrics. You've seen the changes that occur in your health services with accreditation. I'd argue that those accreditation metrics could be far better. We can drive behaviour for almost no cost, and we can enable ourselves to do really good things by changing the drivers and the metrics in the system to make this a functional system. So one of the ways we do that is to have a single voice. I had the privilege of working with Nicola Roxon many years ago when she was a health minister, and I have to say that was a real privilege. She said to me, if you want to work with government, bring a single voice. We can ignore you and do whatever we want, really, if you don't come with a single voice. Bring everyone to the table in a single voice and establish 3 joint priorities. Give me a 1-pager and a clear bottom line budget. And I have used that for the last 10 years, and I've yet not to be funded for the work that I've done. It's not easy, you have to do it together, and it takes a long time, but it works. So when I became the director of Monash Partners, because I passionately believe in collaboration and these stages to come together, I said, this is no point in doing this in Victoria, we need a national body. We are 24.5 million people. We need to compete with the rest of the world, not compete with ourselves. So we formed a national alliance, and originally the first 4, which the red dots there, who are accredited, said, oh no, we're very elite, it should just be us. But then we talked about it and we said, no, this is really about healthcare improvement. It's not competitive. We need a national focus. And we now have that. We now have 7 centres and 2 centres of regional innovation and health. And we have come together in fierce collaboration. I can't think of a group of people I'd rather work with, and the common sense conversations that we have. So what we know is that these centres are health services led, and that is different to other countries. We do have strong geographical spread. We cover 95% of health medical researchers, and at the moment 78% of health services, and that is expanding. We can present unprecedented opportunities for collaboration, shared learnings, leverage, pace and scale and value add, but most importantly, we can start to change those systems levels. So if we're going to do that, and I don't want you to look at the detail here, but this is how we're doing it. We talked the Medical Research Future Fund into not funding us independently. They funded that $10 million to all of us. Our agreements we're signing at the moment mandate that we have to work together. And they did that because we said, please don't make us compete. At first, they were going to make us all put competitive bids in. We said, please don't do this. This is a space we need to collaborate with. We'll compete with each other for competitive funding rounds, but we need space where we can collaborate. We've formed 4 committees, and just to highlight one of them, and the most important, is on consumer and community engagement. And in the next 12 months, we will end up with a national framework and hopefully a whole series of recommendations about mandatory, meaningful community engagement in everything we do. So we've been funded for Indigenous health, data-driven clinical improvement, health services research and community and consumer involvement. That's a relatively small amount of money, and we will do a great deal with it. So this is what we want to aim for, is a system where we consistently come together and say, actually, how do we allow the drivers to do this? This does not cost money. This is policy, it's brave government, and it's collaboration. And it is absolutely fundamentally important that we have a consumer and community voice there to deliver this system that we're talking about. So what do we mean by consumer engagement? It's great to give them information. It's even really good to consult. That's usually after the fact. Involving? Fine. Collaborating? Not bad. But actually, if we really want to empower them, we need to have a partnership model. They are the experts in their experience. Not necessarily elite capture, meaning people who are the advocacies and almost part of an industry itself. They have an important role, but the patients in the everyday community we deal with. We need to move to a different level of engagement to do this, and we need to do it across the whole series. And this is indeed how our research team have worked for a long time. This is based on the US model, where you engage stakeholders and you take them on the whole journey. It's strategic, it's prioritised, it's big picture, and it has impact. We've used this with small initiatives that philanthropy has funded, and we've turned that into $15 million initiatives that have been adopted by WHO and around the world in 74 countries. It's doable, it takes time, it's strategic. One last thought, we have a fantastic health system. It's far from perfect, but we're actually at a pretty good place to start with. This is actually where we are at the moment. Australia and UK are really at the forefront. And indeed, in terms of cost and performance, this is fine. But the individual patient experience is lousy too often. So we've got a really good opportunity and a really good health system to collaborate really well, and these centres offer us the opportunity. What we can do better is exactly what we've heard about today, because this doesn't tell us about the individual. So I'll leave you with those facts that I started with. Our community are the funders and beneficiaries of healthcare and of research. We are all collective custodians, and that should not be left to anybody to do without all of us together. Healthcare improvement is not a competitive space. Nothing about us that's without us, and it's our responsibility. If we really want to have impact, we need to do it together. Thank you.